Welcome back to the deep dive. If you're looking for a clear, high-yield breakdown of a complex medical topic, well, you're definitely in the right place.
Yeah, absolutely.
Today, we're diving into psychosis. We've basically got a stack of focused revision notes right here. And our mission really is to unpack them, pull out the essentials, and give you a solid, memorable overview.
Exactly. Think of it as your shortcut to getting a good grip on psychosis, straight from this source material we have.
Perfect. We're taking those detailed notes and just distilling them down, highlighting the core concepts and, the connections you need, whether you're revising or just want to understand it better.
Precisely. We'll guide you through.
Okay, let's unpack this then. First things first, what is psychosis fundamentally? Our notes describe it as a severe mental disorder.
Yeah.
Where there's a significant loss of contact with reality. It's not just feeling a bit off, it's quite profound.
Right. It fundamentally alters how someone perceives the world. And that loss of reality contact, it affects, multiple areas.
Yeah.
Their thoughts, perceptions, emotions, even their behaviors.
And the classic symptoms we often associate with it. What do the notes highlight?
Well, the notes point to the common ones. Hallucinations, sensory experiences without any actual external stimuli, like hearing voices. Then delusions, which are these firmly held false beliefs, really not based in reality.
Right.
And also disorganized thinking, where speech and thought processes can become quite jumbled or illogical.
And crucially, this state impairs a person's ability to function day to day, right?
Exactly. That impairment in daily functioning is key.
So is it always like a standalone condition, schizophrenia, for example?
No, and this is a really important point from the notes. Psychosis can be a primary condition, yes, but it can also show up as a symptom of other conditions. Things like mood disorders, severe depression, or bipolar disorder. Certain neurological conditions, too, or even substance misuse. The core feature, though, is always that altered perception of reality. That's the thread.
Got it. So a state of altered reality, potentially with different root causes. Okay, moving from what it is to why it might happen, the etiology. The notes say the exact cause isn't fully understood.
That's right, which honestly is common for many complex brain conditions. But they do point towards a combination of factors.
Like a mix.
Yeah, it's seen as an interplay between sort of genetic vulnerability, neurobiological factors, things happening in the brain, and environmental influences.
And specifically about the brain, what neurobiological factors are mentioned?
The notes implicate disruptions in brain chemistry. They specifically mention excessive dopamine activity as a key factor.
Ah, dopamine, okay.
And they also mention structural and functional abnormalities in the brain itself playing a role.
So it's a complex interaction, your genes, your brain chemistry and structure, and life experiences. Which leads us nicely to risk factors. This is where it gets really interesting, doesn't it? What makes someone more susceptible?
Yeah, the notes list several key factors that increase the likelihood. A big one is family history of psychotic disorders.
Makes sense, linking back to the genetic side.
Absolutely. Substance abuse is another significant risk factor mentioned. We'll see that pop up again.
Right.
And early childhood trauma or neglect also feature quite prominently in the notes.
What about other biological factors beyond just genetics?
Well, the notes include things like prenatal exposure to infections or toxins, certain medical conditions like brain tumors, for instance.
Okay.
And even just high levels of stress are listed as contributing risk factors. These are all points the notes flag as increasing vulnerability.
Wow, it really gives you a sense of the different pathways that could potentially lead to this state. So we've covered the why. Now for the how, the pathophysiology. What's the actual mechanism behind the symptoms?
Okay, so the notes explain it involves dysregulation of neurotransmitters. They specifically point to dopamine again and also glutamate within various brain circuits.
So like the brain's chemical messengers aren't quite working right?
Exactly. Think of it like the signals aren't being transmitted correctly. It's not just on-off, it's about the balance and flow.
Right.
And the notes add that this dysregulation is linked to those structural and functional abnormalities we mentioned in key brain regions involved in processing perception, thinking, emotion.
And these physical changes contribute directly to the symptoms people experience.
That's the idea, yeah.
Yeah.
The changes contribute to the hallucinations, the delusions, the disorganized thinking.
Okay. Now, if someone presents with these symptoms, clinicians obviously need to think about what else it could be, right? The differential diagnosis.
Absolute crucial step. The notes really emphasize this. You've got to rule out other conditions that might look similar on the surface.
Like what sort of things would be on that list?
Well, the source lists mood disorders that can have psychotic features, so severe depression or mania. Substance-induced psychosis is a very common one to consider. They also mention delirium, the acute state of confusion, often from a medical illness.
Right, different from psychosis itself.
Exactly. And other general medical conditions that can sometimes mimic psychotic symptoms. It's all about figuring out the primary issue.
Makes total sense. Need to treat the right thing. Okay, let's switch gears slightly to epidemiology. How common is psychosis? What are the numbers?
Right. The notes give us the UK figures. Prevalence is about 0.5% to 1%. So that's the percentage of the population affected at any given time.
Okay.
And incidence, so new cases, is around 26.6 per 100,000 people per year.
And when does it typically first show up? Is there a usual age?
Yes, it usually emerges in late adolescence or early adulthood. The notes specifically highlight 15 to 30 years as the peak age range for onset. That's a key detail to remember for revision.
15 to 30. Got it. Any differences noted in who gets it? Demographics?
Yeah, the notes mentioned a potentially higher risk in men and possibly in some racial or ethnic groups, but they also say there's variation depending on location and specific population characteristics.
Okay, so 1530 is definitely the number to lock in for onset age. Let's try and visualize what it actually looks like in a person, the clinical presentation. We touched on the core symptoms earlier.
Right. The notes give a bit more detail. Hallucinations, as we said, sensory experiences without external stimuli. Seeing things, feeling things, but most commonly, it's auditory hallucinations. Hearing voices is very typical.
Right, hearing voices is often the one people think of first, isn't it?
It really is. Then there are delusions. These are those strongly held false beliefs. Not just odd ideas, but fixed, unshakable beliefs. Often paranoid, like believing you're being persecuted, or grandiose, believing you have special powers or importance, and they aren't easily corrected by evidence.
And the disorganized speech or behavior, what does that look like?
This reflects difficulty with thought processes. Speech might become incoherent, jump between unrelated topics, or just not make sense. Behavior can seem erratic, unpredictable, maybe inappropriate for the situation.
And the notes mention other symptoms too, beyond those main three.
Yes, they include what are sometimes called negative symptoms. Things like social withdrawal, reduced motivation, almost like a flattening of emotion.
Okay.
Emotional instability can be there too, and impaired cognition, so problems with memory, attention, general thinking ability.
Are there other associated features?
Yeah, the notes mention agitation or aggression can occur. Further neurocognitive impairment. Depression is common, sometimes severe enough to be psychotic depression, and importantly, thoughts of self-harm.
Right. And as we mentioned earlier, these symptoms can appear across different underlying conditions.
Exactly. The notes list where psychosis occurs. Schizophrenia is the classic one, but also severe depression and bipolar disorder. Puerperal psychosis, which happens postpartum. Brief psychotic disorder, which is short-lived. Certain neurological conditions like Parkinson's disease. And, of course, drug use, both prescribed meds and illicit substances.
That's a pretty broad list. So how do clinicians actually figure this out? The investigations, it starts with talking to the person, I assume.
Absolutely. The notes stress diagnosis begins with a comprehensive psychiatric evaluation. That means taking a detailed history background, symptom timeline, any potential triggers.
Right.
Then a mental status examination to assess their current state, mood, thought process, perceptions right now, and a specific symptom assessment to really pin down the nature of the hallucinations, delusions, disorganization.
Okay, and what about the medical tests listed in the notes? Why those specific ones, like LFTs and FBC?
Right, the notes are clear on the reasons, which is high-yield info. Liver function tests, LFTs, and a full blood count, FBC, are done partly to screen for alcohol misuse.
Okay.
Alcohol can cause abnormal liver markers or macrocytosis, those enlarged red blood cells.
Got it. Specifically looking for alcohol as a possible factor. What about the others? Serological tests?
Serological tests are included to check for syphilis, because neurosyphilis can actually cause psychiatric symptoms.
Wow.
AIDS screening is mentioned because of the increased risk of co-occurring infections in some populations, which can affect brain function.
And the urine drug screen seems fairly obvious.
Yeah, that's specifically to detect recreational drug use, like cannabis, which the notes explicitly list as a potential cause or trigger.
Right. And the CT brain scan, when is that used?
That's done if there are focal neurological signs.
Yeah.
Signs pointing to a specific area of the brain being affected, like weakness on one side, numbness.
So not routine for everyone.
No, it's to rule out structural issues like a brain tumor, a space-occupying lesion, or cerebral atrophy, which is shrinkage of brain tissue, only if indicated.
Okay, so targeted investigations based on the clinical picture makes sense. Once a diagnosis is made or strongly suspected, how is psychosis managed?
The notes describe a combination approach. It's usually pharmacotherapy, so medication plus psychosocial interventions, which means various therapies.
And the medication is primarily antipsychotics.
Correct. Antipsychotic meds are really the cornerstone for reducing the positive symptoms like hallucinations and delusions.
And the therapies.
The notes add that psychological therapies are crucial. They specifically list CBT, cognitive behavioral therapy, and family therapy. These are important for supporting recovery and, really importantly, for preventing relapse.
What are the main goals of treatment, according to the notes?
The aims listed are: minimize the time between symptoms starting and getting treatment. Getting help quickly is key.
Right.
Accelerate remission, getting symptoms under control, and then prevent future relapses, using both meds and therapy. And ultimately, maximize the person's ability to return to their usual life as much as possible.
And getting that prompt assessment, sometimes that involves hospital admission.
Yes, the notes state admission to a psychiatric unit might be necessary, especially if it's severe or acute, or if there's a risk to the person themselves or to others.
Okay.
And in situations where treatment is really needed but the person can't consent, perhaps due to the psychosis itself, compulsory hospitalization and treatment might be required under the Mental Health Act. That's the legal framework in the UK. But the initial step is always getting that presumptive diagnosis and a specialist assessment and secondary care.
Do the notes mention specific medication preferences depending on what's causing the psychosis?
They offer some guidance, yeah. For psychosis and schizophrenia, the newer atypical antipsychotics like risperidone or olanzapine are often preferred first line.
Okay.
For mania or hypomania with psychosis, again, atypical antipsychotics are used, maybe with benzodiazepines short-term for agitation or sleep issues, and mood stabilizers like lithium or carbamazepine, but those need specialist supervision.
And if it's part of depression?
The notes suggest that's often linked to the bipolar spectrum and stress that treating the psychosis itself is central.
It really sounds like acting fast, that early intervention is vital.
Hugely. The notes explicitly state that early recognition and correct management of a first episode are crucial for improving long-term outcomes.
And addressing those external factors.
Yes, like substance misuse. Tackling that is highlighted as vital for reducing relapse rates. And involving the family through intervention programs is also mentioned as helpful.
And throughout all this, the importance of respectful treatment.
Absolutely. That's reiterated alongside the potential need for compulsory treatment under the Mental Health Act when it's truly necessary for safety.
Okay, so early intervention, meds, therapy, tackling substance use, family support, those seem to be the recurring themes. What about the long-term picture, the prognosis? What can someone expect?
Well, the notes describe the prognosis as highly variable. It really depends on a lot of factors.
Such as?
The underlying cause, how well someone responds to treatment, how early they got that intervention, whether they stick with medication, the strength of their support system, their overall physical health, lots of things.
Is there any data on that variability? Any stats in the notes?
Yes, they provide some statistics. While around 80% of people do respond positively to treatment within the first year, which is quite high.
That sounds promising initially.
It does, but the picture changes longer term. Only about 20% remain completely episode-free for 5 years. The common course described is an initial improvement, but then often recurrent episodes.
So relapse is common.
It seems to be, yeah.
Yeah.
And they also mention that roughly 15% might experience persistent symptoms that don't fully respond to treatment, even after 2 years.
Okay, so treatment helps most people initially, but it's often a condition with a risk of return. What factors might suggest a tougher road ahead? The poor prognosis factors.
The notes list several indicators that might predict a more challenging recovery. A longer period of untreated psychosis before starting treatment that highlights the early intervention point again.
Right.
An early age of onset or an insidious sort of gradual onset, particularly for schizophrenia. Being male is noted as a risk factor for poorer prognosis.
Interesting.
The presence of significant negative symptoms, like that lack of motivation, a family history of the disorder, lower IQ, lower socioeconomic status, or social isolation, a history of previous significant psychiatric illness, and, crucially, continued substance misuse. That comes up again.
That list really feels connected to everything else. Risk factors, treatment challenges, delays, ongoing substance use, lack of support. They all make sense as hurdles.
Yeah.
Okay, finally, what if psychosis isn't treated? What are the potential consequences? The complications?
Yeah, the notes detail some pretty serious potential outcomes if psychosis is left untreated. Severe social and occupational impairment, making it hard to keep relationships or a job. A significantly increased risk of self-harm or suicide. Worsening substance abuse, which can become a vicious cycle. Increased medical comorbidities, other physical health problems popping up.
Right.
Homelessness is mentioned as a sad but real complication.
Yeah.
And just a drastically decreased quality of life overall.
Those are very stark potential outcomes.
They really underscore the absolute necessity of early detection, intervention, and ongoing support. The notes emphasize these are vital to minimize these severe complications and promote the best possible recovery. It just reinforces everything we've discussed about getting help quickly and comprehensively.
So, wrapping things up slightly, what does this all mean? Let's do a quick memory refresh. Hit some high-yield points straight from these notes for anyone revising. Let's test recall a bit. Can you remember the two main neurotransmitters mentioned as being dysregulated?
Dopamine and glutamate. The notes focused on those two.
Spot on. And what was that key age range for typical onset the notes wanted us to remember?
That was 15 to 30 years.
Yes, definitely lock that one in. Okay, besides hallucinations and delusions, what was the other core symptom area we covered?
Disorganized thinking, or disorganized speech and behavior.
Right. And thinking about the investigations, what was one specific reason a CT scan might be done according to the notes?
If there were focal neurological signs, to rule out things like tumors, structural problems.
Excellent. Perfect. And if we look across management, prognosis, complications, what two major factors kept coming up as crucial for improving outcomes and preventing relapse?
Early intervention was definitely one. And addressing substance misuse was the other big one that kept reappearing.
Absolutely. Those threads run right through it all, don't they? From risk to recovery, hopefully framing these points helps them stick.
Yeah, understanding how all these pieces fit together from the biochemistry to the social impact is really key to grasping the full picture these notes provide.
So to wrap up this deep dive, we've really navigated the essential points from the notes on psychosis defining it. Causes, symptoms, diagnosis, treatment, prognosis, complications, the works. Considering how variable that prognosis can be and how critical early intervention clearly is, here's a final thought. How might understanding those risk factors we discussed actually influence community initiatives or public health efforts? To try and identify people who need help sooner.
That's a really valuable question to ponder as you process all this information, thinking about prevention and early detection strategies.
Definitely something to think about. Now, if you're revising for exams like the MSRA and found this kind of note breakdown helpful, you should absolutely check out passthemsra.com. They've got loads of resources like this.
Yeah, great resources there. And you can find some free materials to get you started over at freemsra.com as well.
That's passthemsra.com and freemsra.com. Thank you so much for joining us for this deep dive into the notes on psychosis.
Hope it was helpful for your learning and revision.